I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Welcome back to Dementia Matters. Today I'm joined by Drs. David Berron and Lindsay Clark. Dr. Berron is a research group leader at the German Center for Neurodegenerative Diseases, known as DZNE, in Magdeburg, Germany, where he leads and heads the clinical cognitive neuroscience group. He is also a scientific co-founder of the startup company Neotiv, which created the phone app we will be talking about today. Dr. Clark is a licensed neuropsychologist and an assistant professor here at the University of Wisconsin in the Division of Geriatrics and Gerontology at the UW School of Medicine and Public Health. Dr. Berron and Dr. Clark worked together on a study published in March 2024 that looked at ways to detect cognitive impairment via a smartphone app, building on recent efforts to incorporate remote memory assessments into research and clinical care. Drs. Berron and Dr. Clark, welcome to Dementia Matters.
Thank you.
Thanks. Happy to be here.
And going forward, of course, we know each other, and so we'll call each other by our first names. But I do want to start by talking about your publication, which is titled A Remote Digital Memory Composite to Detect Cognitive Impairment in Memory Clinic Samples in Unsupervised Settings Using Mobile Devices. And this is based on your study where you looked at thinking tests completed by 199 people of various cognitive abilities on a smartphone. So before we talk about your findings, I'm hoping you, David, can share for our listeners why digital testing is important in the field and why you chose a smartphone app specifically.
Yes, thanks. Happy to do so. So I think there are several advantages of smartphone-based testing or overall digital testing. And when it comes to smartphone, it's specifically that they are scalable and more accessible. So because almost everyone has a smartphone nowadays, and also, as you can imagine, during the Corona pandemic, that actually even has become more. On the other hand, when we think about one-shot single tests that we do, they always only give us a snapshot in time when it comes to cognition, but our cognitive performance actually fluctuates over time. So smartphone-based assessments give us the possibility for repeated testing at different times and different days that then might give us a more representative picture of our cognitive performance. And then that also comes with higher ecological validity because these tests can be done out of the testing environment or the hospital and actually at the comfort of our own home environment. And finally, maybe another important aspect is that the digital metrics that you can actually record with a smartphone, such as response times or also like movement over the screen, allow for more fine-grained outcomes that might be particularly interesting to detect very, very subtle cognitive impairment in early stages of the disease.
Yeah, I really appreciate your answer as someone who doesn't actually administer cognitive testing in my memory clinic, but relies on it so heavily in understanding what someone might be experiencing and how they're performing. And two things I take away from what you said are, one, it's being done in their environment. You know, a memory clinic environment is not their everyday life. And then two, there are factors that we can't really assess in everyday environments that you're talking about that a phone might be able to pick up on, response time and such. And I'll be asking you, Dr. Clark and Lindsay, about that in a few minutes, because I think that's such an important piece to digital testing, which is still relatively foreign to a lot of our memory clinics. And so before we get to that, though, you know, how does this app work, David? I mean, what did you have the participants do, and what exactly did it test for?
Yeah, so the app overall does memory tests. So it delivers 3 different visual memory tests. So that's important to stress. So it's not verbal memory tests, but you see actually pictures and need to memorize them. The tests have been developed to target different memory networks that are affected in different stages of Alzheimer's disease. And overall, participants get push notifications. So the phone actually sends you a message. And then you have to do an active task. So that's also important to stress. So it's not passively recording in the background, actually tells you when you are on task. Then you actually do the cognitive task and you also know when it's done again. In this particular study, participants actually did a test approximately every 2 weeks for an entire year. And just to quickly describe the test in a bit more detail, for example, in one, participants need to distinguish very similar images just based on their memory. So, for example, they see a certain sofa, and later on they see an almost identical sofa where we just change the shape a tiny bit. And then they actually need to tell us, is it exactly the same? Or is there a change? And then talking about specific metrics, then they actually have to touch the screen exactly at the location where they think that the sofa looks different. In a slightly different test, we show them a room with actually two objects at specific locations. They need to memorize that, come up with a little story, so to link everything in one coherent memory. And then after delay, or we actually cue them with a specific location in the room and ask them which specific object has been there. So as you hear, it's quite challenging tests, but they're also fun. Yeah, that's basically how they work. Another detail, overall, they take 15 to 20 minutes, usually come in two halves. And in our particular study, we did this every 2 weeks. So it's a time effort of 15 to 20 minutes every 2 weeks.
In essence, you've gamified cognitive testing, which is usually not thought to be a very fun thing to do.
Yeah, so we certainly tried, not overdoing it though. It's still a cognitive test, and overall, looking at the usability questionnaires and what people tell us, there's obviously a range, but overall, people enjoy doing the tests digitally.
And just so our listeners know that this wasn't something that was done overnight, how long did it take to actually build this application and the thought that goes into this type of testing?
Yeah, it's actually a long time. So it all started with cognitive neuroscience research. So that was mostly studies using functional neuroimaging to understand how different memory networks are actually involved in specific memory functions. And then at some point, there was the idea that if we really want to bring that to scale, it actually needs to go in a smartphone app. So I would say overall, that's at least a decade. And when it comes to the specific technical implementation, that's roughly the last 7 years.
Yeah, that's incredible. So thank you for giving those numbers. Now, Lindsay, you must have been somewhat skeptical about this from the beginning as a neuropsychologist in a memory clinic. How accurate can an unsupervised smartphone app be in detecting cognitive impairment? And then with that answer, what are the advantages and disadvantages of being able to do this clinically?
Yeah, I was a little bit skeptical at the beginning because it can be hard or difficult to collect quality data remotely when you're not in the room. As you know, this is really different from what we do in a memory clinic. In a memory clinic, we're in a room with a person, we're administering standardized tests, we're watching them take these tests, seeing how they're doing it. We've limited any distractions, so it's a completely quiet environment. And, on the other hand, in the smartphone app, people are doing these assessments wherever they happen to be when they get the push notification with whatever tends to be going on in their life. So it's a really different type of environment and scenario for testing cognitive function. As far as how accurate an unsupervised app can be, we've really only started to conduct studies to answer this question. Much of the early studies were looking at feasibility, meaning can people actually download the application and perform the tests? Do they respond when they get the push notifications? Do people feel like they enjoy doing the tests? Are they satisfied? And so there was a lot of development in just making sure that an application was usable, user-friendly, and people could actually sit down and do it. But there have been studies over the last few years comparing the test performance data that we get from the smartphone application to in-clinic neuropsychological standard tests. And we do see correlations between what we, how people perform on these smartphone applications and the memory tests that we do in person in the clinic. So we do think they can accurately measure what we're trying to measure as far as how well a person's memory is functioning. And I'll probably let David go into a little bit more detail in our study about how well these applications can detect cognitive impairment. We do feel like we are able to pick up cognitive impairment, but I'll let him talk more about the details of that particular, of kind of our particular findings in this study. You asked about the advantages and disadvantages to doing this or being able to do this clinically. I think there are a number of advantages that David already mentioned earlier. As far as in the clinic, I think one of the advantages is potentially providing more accessible cognitive screening tools for clinicians to be able to have in their toolbox. Smartphone applications provide an opportunity for patients or people to be able to perform cognitive testing outside of the clinic as well. So potentially giving primary care or other providers a tool that they can have people use in their home, doesn't take up extra time in the clinic. Patients can do these and potentially bring results back to their clinical providers. Just being able to provide more options for cognitive screening, I think would be a really wonderful opportunity to use digital technology for. We know that there's a lot of barriers to getting cognitive screening or cognitive testing in healthcare. And so that's one potential advantage clinically for these types of tools. You also mentioned in the memory clinic, it can be, kind of not exactly what we do in our home environments. So people can be anxious about having memory testing when they're in the clinic. There's kind of that white coat effect of being observed by someone when you're doing testing. So another advantage having a tool like this is that people could do testing in an environment where they feel more comfortable and not having to be observed by someone while they're doing these tests. And lastly, as already mentioned, when we do these memory tests clinically, we're doing them all in one single shot. So we have people come into the clinic, they're doing all the tests in one, maybe 2-hour period. And if someone's having a bad day or is really tired or is in pain that day or is, having a lot of stress, that can affect their cognitive test performance and make it more challenging to detect cognitive impairment. Whereas these kinds of digital tools can be done in a briefer period over maybe a week or 2 weeks, so we can get a more representative sample of a person's actual cognitive function, with the idea maybe to reduce some of that noise related to other factors that can affect cognitive testing. As far as disadvantages, I think that the flip side of not having people in a structured environment is that there's a lot of potential distractions going on around them that we can't control for. When we do memory tests, we show people some images and then we need them to come back and do them on their smartphone, maybe 30 minutes later, an hour later, but people might get sidetracked by things going on in their life and then we might not have that data. So there's some issues with that loss of control over that environment. People also have different devices, and sometimes with certain tasks, this can affect how they see the stimuli or if it's measuring response time, kind of how they're responding. So those are, again, other factors that can create some noise in data collection. And I think lastly, a disadvantage is the digital divide, meaning that there are a number of people in our country who don't have access to devices, or maybe have access to devices but don't have access to the internet or to a cell phone tower nearby. And so that can limit those individuals in being able to access a smartphone application for this kind of testing.
Well, thank you, Lindsay, because you set this up very nicely. There are certainly pros to this. There's certainly some limitations that need to be addressed. But cognitive testing is incredibly important in the evaluation of someone who's experiencing thinking changes. And so any way that we can improve our access as well as the testing itself seems like a worthwhile endeavor. And what I'm learning from the two of you, though, is a lot goes into this before it hits the clinic, which will be one of my questions at the end. A lot has to go into feasibility, usability, accuracy, validity. And so this is not something that can happen in a year. Frankly, it's taking over a decade to get to this part. And so I mention this because now I want to know what you guys found and what this article talks about. So David, I'm going to start with you. If you can share, with our audience, what did you find in this study? And then in that answer, if you could talk about something that comes to my mind is, how do you know people aren't cheating? Or how do you know people aren't distracted? As Lindsay has said, that they didn't leave and come back to it because it's unsupervised. What are other things that you consider other than, did you detect impairment?
So overall, I think we can summarize what we found mostly in 2 points. So on the one hand, and that adds exactly to what Lindsay already said, we looked at the construct validity. So we were interested whether what the app or the smartphone actually measures really compares to what we measure in a face-to-face standardized setting in the memory clinic. And there we use the preclinical Alzheimer's cognitive composite. So that's a composite score out of several cognitive tests covering memory, but also covering executive functioning, for example. And what we found is that it actually compares quite well. So there's a high correlation between what the app measures and what we measure in the clinic. And as Lindsay also already touched upon, that is actually an impression that you get from the entire field at the moment. So if we would travel back like 5 years, I think the big question was, do these novel tools actually measure anything meaningful? But now if you look across studies and across tools, I think we can take from that it's actually possible to get valid, reliable data, and that it's also feasible in the target population. So in a group of older adults and even patients. I think that was one of the main first points. And then critically, we were interested whether we can use the smartphone derived score to actually classify participants into those that we would rate or that actually would show cognitive impairment versus those that actually don't show cognitive impairment. And here we actually calculated this analysis and found that it's actually very good in discriminating these two groups. Yeah, I think that's the main takeaways. But yeah, there are challenges too, as you actually touched upon too, cheating and also distractions. So how do we actually get to those? So first, for both these scenarios, we try to actually encourage people not to do. So on the one hand, we tell people, okay, please go to a quiet environment, take your glasses, take care that there will be no distractions, and only then actually start the cognitive assessment. And I think for cheating, and that's also like what other groups out there are doing, we remind people that this is for research and that it's important that we get the accurate scores and that it's not necessary to cheat. And I think overall, there's not a strong interest actually to cheat in these kind of studies. But yes, I guess the uncomfortable answer is that we cannot completely be sure that people don't. But regarding cheating, one thing that's maybe important to stress is in the visual memory test, it's really, really difficult to cheat because it's not a verbal list of words that you can just note down. You actually see images. Later on, you see similar images, and you don't even know what will have changed on the following image, right? So I think their cheating is actually, pretty unlikely. When it comes to distractions, we then rely on self-report. So following the test, we actually ask people, how well could you concentrate and have you been distracted? And just to go to the specific study that we're talking about, people rated their overall concentration levels at a 4 out of 5, so so they could rather concentrate well. And when we asked them for every session that they did, actually how often they were distracted, 8% of sessions were actually characterized by a distraction. So again, it's not nothing, but it rather has a minor influence. For now, we just have to live with that result. In the future, there could even be the possibility to actually flag sessions where there were distractions and then, for example, discarding them.
Lindsay, as a clinical neuropsychologist and researcher, what is the potential impact of having this unsupervised remote cognitive testing on a phone for both memory care as well as research into cognition?
Yeah, so I think in research, the potential impact is the ability to study outcomes that we haven't been able to study easily in the past. So, for example, we can try to measure really early cognitive changes associated with Alzheimer's disease. When we try to do this in the research lab now, we have participants do paper and pencil tests every year or every 2 years. And then we look to see if over a decade, people are declining on these cognitive measures over time, if they have brain changes associated with Alzheimer's disease, for example. But by being able to measure cognitive function more frequently, we can actually look, over 6 months or over a year, do we see these cognitive changes? And this might help us to be able to detect these changes earlier and be able to intervene earlier in the future. And I think, speaking of intervention, there's a number of clinical trials going on looking at, are new treatments for Alzheimer's disease effective? But in order to answer that question, they have to have a cognitive or other meaningful outcome to measure over time. And so by developing tests where we can, better assess earlier cognitive changes in these clinical trials, we might be able to see if there's an improvement in cognitive performance over time sooner than we would, because of a new drug, for example, than we would if we were having people do paper and pencil tests again at every year or every 2 years. So I think it just gives us the potential for having more robust or more sensitive outcomes to these cognitive changes that we really want to be able to measure. Additionally, smartphone applications or unsupervised remote testing applications can help us potentially to expand the sample of people who are enrolled in research. So one of the issues that we've struggled with in research is that our samples of people that we're measuring are not representative of the people who are at highest risk for Alzheimer's disease, those from historically marginalized communities, maybe those from rural areas. And this is something where we could potentially expand access to people to participate in research studies if we have something where they can do it in their home, it's accessible, and then we can really look at this disease and disease process in a more representative way. So I think in research, there's a lot of potential for these unsupervised or just generally remote testing applications. Clinically, I think, we've talked about the barriers to getting cognitive testing in the clinic. There's often really long wait times to see a specialist. Primary care providers don't have a lot of time in the clinic to be able to fully assess cognitive function and provide a diagnosis. And so, creating some more tools that would be available for clinicians to be able to access, have their patients do outside of the clinic setting, but still be able to be used for treatment planning or for triage to a memory specialist or for, potentially helping with a diagnosis. I think these are potential clinical applications that remote assessment paradigms can help to address.
So right now, it seems like the biggest impact is going to be in research, and then eventually this will translate to a clinical environment. Does that seem fair?
Yeah, I think that's fair. I think it's being moved into the clinic. Like, there is research studies about, would this be effective, or how do providers find this useful in the clinic? So I think in research, yes, for sure. And then I also think there's research studying how to implement these tools in the clinic that I think is really important. So I think it is moving into the clinic slowly, but still in the research context.
But these spaces are blending. That's helpful. So thank you. And that leads me to my question for you, David, of what improvements do you think this kind of app and assessment style is going to require before it's translated into these large scale settings, clinical settings?
Yeah, as we discussed before, I think that research in the last years has really demonstrated that really a variety of different tools is already at a stage where they are feasible, reliable, and where they give valid results. One thing that's I think missing to really move it into clinical settings is that there's no clear framework yet that specifies how novel digital cognitive assessments need to be validated, what they actually need to fulfill. So, for example, even beginning from what's the gold standard that we compare them with, or what's the proper comparison group. And I think this really makes it at the moment difficult to judge the quality of different tools, and might be one hurdle. On the other hand, as Lindsay said, there is already implementation studies, but it's still not entirely clear how to implement them and in what setting. And it's even more complicated because that's different across different healthcare contexts. So will it be an on-site short digital cognitive assessment that's actually done at the doctor's office? Or is it something that's remotely done, where people actually maybe get it prescribed, but then continue testing at home before they come back with the results? I think that's still something that's not very clear. But there are already studies testing that in specific healthcare systems globally, actually. And maybe to quickly talk about our own data. So we did a study in the German healthcare system with primary care physicians, but also specialists and memory clinics. And that's exactly followed this remote logic where participants with subjective cognitive decline came to their physician, then got the app prescribed, used them at home for repeated testing over a certain period, and then came back to the physician with the respective results summarized in a physician letter. And in that study, we actually didn't test the diagnostic accuracy. We were just interested in what are the hurdles and challenges to actually bring that into the healthcare system. And the takeaways were actually that the doctors find it feasible. They see an added value more in primary care than in memory clinics because there it's just more important. And I think we need more of these studies to find the optimal implementation, but also critically, we need diagnostic accuracy studies that are not only done in research cohorts, but actually really done in the real world. And I'm pretty sure we will see more of that in the coming time.
Well, to end our conversation today, my question for both of you is then what's the next step? And this is sort of a follow-up, David, to what you said, but what is your next step, both of you, in this line of research of digital cognitive testing in a remote, unsupervised environment?
Lindsay, if I may start, I think we can certainly share that what we have published so far was the cross-sectional data from our study. And we have already worked on the longitudinal data. So with the question whether we can actually not only detect cognitive impairment, but also cognitive change over time. And it actually seems that remote digital assessments are able to detect cognitive change in MCI patients. And that now opens up interesting use cases for clinical trials, but potentially at some point also in healthcare. And I think another really interesting line of research is to detect Alzheimer's disease even earlier than at the mild cognitive impairment stage, already in the preclinical disease stage. And here it will be really interesting to combine digital cognitive testing on the one hand with novel blood-based biomarkers on the other hand to actually add disease specificity to the cognitive assessments. I think that will be really, really exciting in the next years.
Yeah, and I would just add, continuing to validate these paradigms in larger, more geographically and racially diverse populations is needed. We really need to make sure that the tests are measuring what we think they're measuring in everyone and that they're feasible and accessible to everyone. So I do think we need larger studies, and we also need to better identify the barriers that some people will face in trying to access these kinds of tools. So that might be, I've mentioned before, not everyone has smartphones or tablets. Even if people sometimes have a tablet or a laptop, maybe they don't have access to the internet or to a cell phone tower nearby. And so they won't be able to necessarily engage in how we can try to, better fill those gaps. So I think that's one area of future direction for me, is just continuing to validate these tests in larger populations. And then also thinking about really kind of practical uses. For example, like how many repeated assessments do we need to get the most reliable estimates of cognitive function? We want to do enough to best sample a person's cognitive function, but we don't want to have too much where it's burdensome for participants or patients. So some of those practical questions are on my mind. And then I think, as David discussed, really, how do we implement this in a healthcare system and healthcare systems that vary widely in their workflows and processes across the world? So continuing to study implementation studies of how to use remote cognitive testing to best add value and provide tools for clinicians and increase access to cognitive screening and testing for patients.
Well, with that, I want to thank both you, David, Lindsay, for coming on this podcast today. And for our listeners, that's Dr. David Berron from the German Center for Neurodegenerative Disease in Germany, and Dr. Lindsay Clark from our own University of Wisconsin. Thank you both for being here.
Thanks for having us.
Thanks, Nate.
Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, or wherever you listen. Or tell your smart speaker to play the Dementia Matters podcast. Please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. If you enjoy our show and want to support our work, consider making a gift to the Dementia Matters Fund through the UW Initiative to End Alzheimer's. All donations go toward outreach and production. Donate at the link in the description. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center at the University of Wisconsin-Madison. It receives funding from private, university, state, and national sources, including a grant from the National Institutes on Aging for Alzheimer's Disease Research. This episode of Dementia Matters was produced by Amy Lambright-Murphy and Kaylin Rauerdink and edited by Alexia Spevacek. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center, check out our website at adrc.wisc.edu. That's adrc.wisc.edu. And follow us on Facebook and Twitter. If you have any questions or comments, email us at dementiamatters@medicine.wisc.edu. Thanks for listening.